I would like to invite Dr. Amit Mahajan, please. He will be talking regarding Acriol AC Toric lens.
Good afternoon, everyone.
Harsh,
At the outset, I would like to thank All India Society and Care Group for giving me this opportunity. I don't have any financial disclosures. So this is a well-known fact that astigmatism not only reduces the visual quality, but it also hampers the depth perception as well as the quality of the vision. 30% of the eyes, they do have astigmatism of more than one diopter. Either you do LRI or you do OCCI, nothing is as precise, as accurate as like a toric lenses. But at the same time, even slightest of the rotation, like even 10 degree of the rotation, can also cause 30 degree loss of the total astigmatism correction. So I would like to share this one interesting study in which 95% of the surgeons, they do agree that clinically significant astigmatism has to be corrected at the time of the surgery. But 73% of the surgeons, they even do not attempt to correct it at the time of the surgery. So what are the main hurdles that I think in the toric implantation? So the first and the most important is accurate pre-op assessment. There are so many variables like keratometry, axial length, accurate formula, and all those things, they lead to confusion. So we are not sure that our pre-op assessment is correct. Even though we are sure that we got accurate pre-op assessment, then while coming to the implantation of the toric IOL, again there are so many variables like which marker, sitting position or lying down position, marker or like scratch mark or anything that leads to confusion. Even though we get accurate pre-op measurement, we got accurate bang on IOL in place, but then we are not sure about the rotational stability. So all these are the main hurdles. So why I was not so keen for the toric? So mainly because of so many variables like keratometry, what I have told you, that keratometry, axial length, formula, markers, sitting position, lying down position, everything, and that all leads to the confusion. So is it the only factor that was preventing me from going to toric? No. The main factor was the affordability. As most of the multinational companies, they do have accurate toric IOLs, but that is beyond the range of me and my patients. So the main concern was of the affordability. When it comes to some Indian companies, they have come up with the excellent solution. But again, there is the issue of consistency and predictability. So here I found Acriol toric more consistent and more predictable. What is the most important thing, I think, is the proven Acriol platform. I don't think that there is any surgeon from Srinagar to Port Blair who have not used Acriol lens at least once in his life. So it is a more proven platform. It is available from 0 to 30 spherical, from 0 to 6 cylinder. So it covers the whole of the range. And the most important thing is the tackiness control technology, with which the posterior surface they have treated such a way that there is a less PCO and that posterior surface adheres to the PC, and that prevents the rotation. So let's go quickly to my experience. For this particular study, I have considered 180 patients who are having cylinder of more than one diopter. All the biometry done was on IOL Master 700. Formula used was Barrett. Again for toric calculation, Barrett was used. So this is the short video in which I would like to show you that Barrett calculation is not a big deal. It is easily available on the Google. You can Google it for the Barrett. Once you have Google it, you can get it free from APCRS website. In that formula, you have to just enter your doctor's name, patient name, which eye, right or left eye, steep K, flat K, axis, ACD, W to W, and that's all. Many of the people, they hesitate going for the Barrett only because they think that Barrett is not incorporated in my ultrasonography machine or my optical, then how can I go for it? So this video is only for them. It is only 30-second video in which you have to just fill the everything data, and within a fraction of second you get it. So within 30 seconds you get accurate toric power and toric placement also. So this is my short video in which I will show you how to implant Acriol EC Toric. I won't go into the details, but cortical cleanup is something which I feel is a more important thing, because unless you left some cortex, that will lead to fibrosis and rotation. Second most step is the proper IOL loading. The IOL has to be loaded under actual visualization under the microscope, and make sure that optic and haptic are free, just like as in the cartridge they are freely moving. I always prefer hydro implantation. This is a hydro implantation of Acriol EC. I just want you to see how easily it goes inside the bag. Nothing, no visco is used. It is going very smoothly. Once it is inside the bag, you just cross align the IOL, remove the traces of the visco. Even if you implant it hydro, just go behind the lens and remove the whatever OVD is remaining behind the lens, and then you have to do the final alignment. So first gross alignment, remove the OVD from behind the IOL, and then final alignment. So this is the final alignment. I will just skip. So these are some of the pictures which are showing how exactly or how bang on this IOL sit on the axis. This is a Chalisgoan measure. If you have it, then nothing like it. But even if you don't have it, you can do it manually very well. There are few apps like Dr. Saurabh Patwardhan's Toric Patwardhan app, or Dr. Swapnil Kothari has invented one precise Toric calculator app. I don't have any financial inclusions, but these are very effective and very useful apps. But if you have Chalisgoan, then nothing like it. So regarding post-operative examinations, I have checked the axis placement on eye tracy, and as you can see, there is only 3 degrees of rotation. That means the IOL is bang on. It is sitting bang on the axis. Regarding post-op uncorrected visual acuity, nothing was special. But what I want to draw your attention is, you can see that in 70% of the patients, the rotation was only 0 to 5 degree, while 5 to 8 degree was in remaining 16%, and only in the 14% it was having 8 to 10 degree. What I mean to say that in all the cases, there is no one case in which it was more than 10 degree rotation after 6 months of post-operative period. So suppose we want to realign the toric IOL. You just have to wait for the 3 weeks. And after 3 weeks, if you feel that it has to be redialed, then it is very simple and accurate. Go to www.astigmatism.com, or you can take help of the eye tracy. Just for the sake of showing you this case in which eye tracy, it is showing 69 degree of rotation. So this IOL has to be rotated. So you can select like this, and how and where, that is also shown on the eye tracy. This is the green axis which is showing the intended axis, while that is blue line that is showing your actual IOL where it is sitting. So if you have eye tracy, you can go for it. So to conclude, tips for the successful and predictable outcomes. So regarding biometry, I would like to recommend one man, one machine, and one technique. This is not like that today you are taking K readings from autoref, tomorrow from your optical biometer, day after tomorrow from pentacam, or like that topographer. No, it has to be one machine that has to be customized. Again, technician, either you or technician has to be the same, because we can customize. And again, technique. If you are using Barrett, go for it. Not like that today Barrett, tomorrow SRKT. So one man, one machine, one technique, that will save you biometry. Regarding SIA, with the concept of centroid SIA, now it is a well known that SIA doesn't only have the magnitude, it has got direction also, vector also. So please calculate centroid SIA. And with the advent of this centroid SIA, most of the surgeons doing 2.2, they have got their SIA is 0.25 or even less than 0.25. Gone are those days when keratometry is only K1 and K2. Now with so much of talking about posterior corneal curvature, one has to actually calculate it by like machines like Pentacam or IOL Master, or you just have to fill all the data to the Barrett, and that will take care of the posterior corneal astigmatism. But don't forget about posterior corneal astigmatism. Barrett, forget everything. When it comes to the toric, only Barrett and Barrett. Rest, forget about everything. Regarding that reference mark, either you do it in a sitting posture or in a slit lamp, I would highly recommend don't do it with your marker, because ink can fade, it can spread, or by the time you take the patient to the OT table, it may vanish. So I always recommend to do a scratch mark. Regarding Rexis, it has to be central 5 millimeter. If not 5 millimeter, then it at least it should cover 360 degree of the optic ideally. But somewhere, if you think your Rexis is elongated, doesn't matter. You can put safely toric lens. What if your Rexis get extended? At that moment, you have to be sure that your toric IOL is going to sit inside the back. Then and then only you implant. Otherwise, don't go for the toric. Like one haptic in the back and one haptic in the sulcus. No, that is not the ideal position for the this. Regarding OVD removal, this is a very small and short video.
Little
but for the sake of the time being, I will skip it. But the only thing that I want to emphasize, whichever technique you implant, but with the irrigating cannula, you just go behind the IOL and remove even traces of the OVD that is remaining. Ensure proper positioning even after removal of the speculum, because in topical, when we remove the speculum, most of the times patient blink vigorously. So ensure that IOL is proper in sitting. And this is what I recommend you, that after doing surgery, ask the patient to lie down in a supine position with closing the eyes for 1 hour, because most of the time that rotation occurs in first hour of the post operation. So ask him to lie down, just close your eyes and supine position for 1 hour. Again, minimum medications and avoid eye rubbing. So there is no shortcut to the torics. You have to learn from your own mistakes, you have to work hard, and you have to implant the torics. Unless and until you implant toric, you cannot recognize your results. And once you recognize your result, then there is nothing wow like a toric. So practice makes the toric perfect.